Hey guys, welcome to the Dr. Mudgil podcast. This is episode number 71. We are just rolling up on April. April is just right around the corner, and spring is in the air. Today's opening day for baseball. The Yankees are playing at home. I'm actually a Mets fan. Mets are in Miami, I think, today. But it's exciting that spring is in the air. So in this podcast, we are going to discuss something that we get a lot of questions about, both like through social media and also from my patients, and that's hair loss. And we've been seeing, so there's lots of types of hair loss, and there's a lot of like esoteric forms of hair loss. But I want to talk about two common types of hair loss. One of which we've been seeing like a tremendous uptick of recently, and then one which dermatologists have just been dealing with since the dawn of dermatology. So the first type of hair loss is something that's called telogen effluvium, and that's kind of this like rapid loss of hair, and it can happen very acutely. Sometimes it's the type of hair loss that you see after childbirth in some women, where their hair starts shedding pretty dramatically, like a month or two after childbirth. You could see it after an acute illness, like if you're hospitalized or get anesthesia. Some medications can cause it. Emotional stress can cause it, like loss of a loved one or like a bad breakup or something like that. And that type of hair loss is called telogen effluvium. What generally happens is, 2 to 3 months after some inciting event, whether, any of the aforementioned things, whether it be like a physical stress, sickness, mental stress, your body doesn't think hair is essential. And what it essentially does is it shuts down the growth of hair. So hair, just to kind of like give you a little bit of background, the hair cycle has 3 phases. There's the anagen phase, which is the growth phase. Your hair is basically living there most of the time. There's something called the catagen phase, which is a very brief period between like the growing phase and the resting phase. And there's something called telogen. So there's anagen, catagen, telogen. Telogen is the resting phase of hair. So when your hair is just kind of in a dormant phase, the stem cells are kind of recharging, and then you start, you shed your hair, then you start growing again. So for most folks, except for, folks that don't have a ton of hair, like The Rock and the Doc, your hair kind of just cycles through these phases. It's predominantly in anagen, a little bit in catagen, and then telogen for a little while, then gets back into anagen. Now, those telogen hairs, like I'm sure you guys have heard or read, that folks lose like 100 to 150 hairs a day. That's normal shedding. In fact, that is normal shedding. Those are your hairs that are in the telogen phase, and they just basically shed. They usually go into telogen, and a couple of months after they're in telogen, they shed to kind of prepare for the hair to go back into anagen, which is the growth phase. The hair starts from scratch and starts growing again. So that's like literally like 5% of your hairs are in the telogen phase. And those are the hairs that are just shedding while your hair is transitioning back into the growth phase. When you have this condition called telogen effluvium, up to like 50% of your hairs could go into telogen. And instead of losing like 100 hairs a day, you could lose 1,000 hairs a day. And it's very, very dramatic. Like when you wash your hair, you see it like all over your hands. You'll see it in the drain, on your pillow when you wake up. And obviously it's very disconcerting for a lot of our patients. And we've been seeing a ton of that in the last few years, predominantly because of COVID. So during COVID and like pretty soon thereafter, telogen effluvium was a very well-documented result of having had COVID. And in fact, even the COVID vaccination, a lot of our patients went into telogen effluvium after being vaccinated for COVID, whether it's their initial shot or the multiple boosters that they may have received. I guess it's jarring to the system, so much so that your body's just dealing with the vaccination or having had COVID. Your hair goes into this phase of or this condition called telogen effluvium, where tons of your hair go into this dormant phase and starts shedding dramatically. So that's basically what happens. And like I said, we've been seeing a big uptick in that. We've been seeing a ton of it. The good news is, what I tell my patients is, the prognosis is excellent. So, very rarely are you going to like lose so much hair that it's really, visually appreciable. Obviously, like my folks will say, their ponytail doesn't feel as thick if they have longer hair, or they're starting to see more of their part line. But generally, after like the whole thing kind of plays out over the course of a year, basically. Basically, your hair goes into telogen effluvium, everything is cool for a few months. Then like around month 2 or 3, it starts shedding for a few months. Then everything's kind of quiescent, and then your hair slowly starts growing back. Now, as I said, most of this, for most patients, this whole story kind of plays out in a year. But what I have found out from talking to my patients, and obviously it's very understandable. No one wants to wait a year for this to all go down. Once my patients start noticing their hair shedding, they want to do something proactively to get it to come back faster. So there are a couple of things generally that we can do. So the first step is when I see a patient with telogen effluvium, the first thing we do is we draw a very comprehensive set of blood work. We're basically checking for all kinds of things, thyroid, iron, hormones, vitamins, blood counts, a whole gamut of tests, just to make sure that everything is normal. And most of the time, everything comes back normal. So normal blood work coupled with what's called a pull test. When I see my patients, I kind of just gently pull on their hair. And generally what you see is like the hair comes out pretty easily, and there's like a little root and that little ball at the end of the hair. And those two things together are pretty diagnostic of telogen effluvium. Now, once I've confirmed the diagnosis, the next question obviously is like, what the hell are we going to do about this? So there's generally two recommendations I make for my patients. One's like, recommendation light, and you can use topical minoxidil to get your hair to stimulate it to get back. That's Rogaine. You can get your hair to stimulate it to get back into the androgen phase. So, wake it up from telogen and get the hairs to start growing again. But for some reason, a lot of my patients, especially my female patients, are hesitant to use minoxidil. There's a lot of misinformation that's out there about it. So frequently we go to option 2, and that's something that we do called PRF injections, platelet-rich fibrin injections. So platelet-rich plasma, you may have heard of. That's what, like orthopedic surgeons will inject into joints if you have like a joint issue, like into your elbow or your shoulder or your knee. Dermatologists use it for tons of cosmetic stuff. We use it when we do laser procedures, the vampire laser, where you have or vampire facial rather, where you have microneedling done, and then you have PRP applied to the skin after you have the laser procedure done. Is like a very popular Instagram popular cosmetic procedure. So we used to do a lot of PRP in my office, and what we do is we draw our patient's blood, we spin it down, we get the platelet-rich plasma out, and then we inject that back into the scalp. We do it once a month for 3 months. And generally, there's proteins in the platelet-rich plasma which stimulate the stem cell in the hair follicle, which get it to kind of wake up and say, okay, we're going to start growing again. In my office, like I mentioned, we actually do something called platelet-rich fibrin, which is the next generation of platelet-rich plasma. And, it's the same process. We draw our patient's blood, we spin it down in a special centrifuge, we extract the platelet-rich fibrin, PRF, and then we inject that into our patient's scalp. We do it monthly for 3 months to try to break this cycle. So all of my PRP patients, I don't think we've done PRP in my office other than for like laser procedures and that sort of stuff for years. All of my PRP patients, we've transitioned over to PRF injections. And to be perfectly honest, like behind Botox, it's the second most common procedure we do in my office. We do a ton of it. And it works well. It works very well for telogen effluvium. It's hard to tell you or give like a number, like, okay, it helps like, to get 50% of the hair back faster. But most of my patients, they do see a tremendous benefit from it. It basically hastens the course of telogen effluvium and gets the hair back into a growth phase. So that's telogen effluvium. That's a type of hair loss that's transient, which we see a ton of. And, I think that's pretty much all I have to say about that. The next most common type of hair loss is something that's called androgenic or androgenetic alopecia. And that's just, normal, male pattern hair loss or female pattern hair loss. This is folks who have, thinning of their hair as time goes on. And this affects men and it affects women. You see a lot of women who are, postmenopausal frequently that have some thinning of their hair where you can see more of their scalp. So there's a huge genetic component to this, obviously. Obviously I wasn't blessed with great hair genetics, but, The Rock has the same hair as the Doc. So I saw the writing on the wall in my 20s. I knew where this story was going to end. So I got ahead of it. I started shaving my head when I still had hair, so no one could say that I shaved my head when I went bald. I knew I was going to go bald, so I shaved my head before it actually happened. But yeah, I've had to shave my head for 25 years at this point. But obviously, folks that are having thinning of their hair in their 20s, or sometimes even earlier, want to do something about it to preserve their hair. And fortunately, there's tons of stuff, actually, the non-invasive stuff. So I'm not talking about hair transplants. I'm talking about measures that can be taken to help to preserve the hair that you have. So there's essentially two strategies here when I'm thinking about patients with androgenic alopecia. So just to kind of walk you through a little bit of the science behind it. So basically what happens is, there's testosterone in our system. There's enzymes which convert testosterone into something called dihydrotestosterone. In some genetically susceptible individuals, like yours truly, the dihydrotestosterone talks to your hair follicles, and it basically says, no more. We're going to shut down this follicle, and we're going to get rid of your hair. So some of the measures actually involve interfering with that, mechanism of action, basically preventing the conversion of testosterone to dihydrotestosterone, which ultimately affects the hair follicle. So there's, like I said, there's two strategies. So for folks that have hair, the two strategies are starting to have some thinning of the hair. The strategies are basically, you want to keep what you got. So you want to basically prevent further loss. And then the next part of what you want to do is you want to stimulate some growth. So the ways we do that are, I'm talking about for men and for postmenopausal women. We implement these strategies. So there's a medication called FINASTERIDE or PROPECIA. And what that does is it alters the way testosterone is metabolized in your body, and it basically prevents the type of testosterone from forming that interferes with your hair follicles. So that basically prevents further hair loss. What I tell my patients is, we can freeze time, I can put you on this medication, and you'll be able to basically keep what you have, more or less. So a lot of my patients, my male patients, I'm sure a lot of folks that you guys know out there, are on this medication called PROPECIA or FINASTERIDE. I actually use it quite a bit in postmenopausal women as well. The next part of the story is, okay, how do we stimulate some growth? So there's basically two ways where we can do that. So one is MINOXIDIL or Rogaine. So there's the topical version of MINOXIDIL, the 5%, which you apply to your scalp, and it can stimulate growth. But what's become very popular now is the oral version of minoxidil. So minoxidil is actually a blood pressure medication. And when it was being used, folks started noticing their hair growing. It was growing on their heads, but it could grow on other parts of the body as well. And because of that side effect, topical formulations were prescribed that were used for hair loss. But the oral version is actually a lot easier to use. There's a lot better compliance with taking a pill than applying something to your scalp every day. And it just works better. So a lot of my male patients are on oral finasteride and oral minoxidil, and a lot of my female patients who are postmenopausal are on that same regimen. The icing on the cake, what I tell my patients is are PRF injections. So just like we discussed for TELOGEN EFFLUVIUM, those proteins that we get from PRF, platelet-rich fibrin, will stimulate the stem cells for folks who have androgenetic alopecia as well. And for follicles that are kind of like teetering on the edge, it's like, okay, should I stay or should I go? When you use PRF, it basically encourages them to stay and to keep growing hair. So I would say when I describe this to my patients, I say, listen, like 90% of the battle is the finasteride, 9% of the battle is minoxidil, and then the last final percent are PRF injections. And generally, our patients do quite well. So basically that covers androgenetic hair loss for men and for postmenopausal women. But what if you're a premenopausal woman, someone who's still getting their period or of childbearing age and is experiencing androgenetic alopecia? We do see that quite a bit as well. So this is a little bit of a tougher group to treat because, finasteride, you can't use it in women who are of childbearing age, particularly if they're trying to get pregnant. So what I do in this setting is I use a medication called SPIRONOLACTONE, which is something that I use a lot for hormonal cystic acne in women, but I also use it for hair loss in women who are premenopausal. And what this medication does is actually a blood pressure medication, which folks use it's a diuretic as well. It's what folks use when they have swelling in their legs or high blood pressure. An off-label use of this medication is treating hormonal issues in women like hormonal cystic acne or hair loss. Now, you can't be on this medication if you're pregnant, but you can be on it, up until you get pregnant. It's out of your system in a very, very short period of time, like 8 hours or something like that. So for my patients who are not actively trying to conceive, who are premenopausal, this is something that I use quite a bit of. If they're in that part of their life where they're actually trying to get pregnant and have a child, I have them stop, obviously, to prevent any adverse effects of being on this medication during pregnancy. But that basically covers the way I manage hair loss. So again, just to kind of like summarize the things we've discussed. So there's lots of types of hair loss, but the two most common types that we see are TELOGEN EFFLUVIUM, which is this like stress-induced hair loss. And we've been seeing a big uptick of that in the last few years. I think most dermatologists would agree that that's the case. And then there's something that we've seen just a ton of through the years, and that's androgenetic or androgenic alopecia, which is a genetic androgen-driven thinning of the hair as time goes on. So if you have any questions or comments about this stuff, please, you can, write them in the comments, and I'll be happy to address them maybe in a future podcast, or just, I'll answer your question in the comment section. So with that, I hope you guys all have a wonderful beginning of April, a very restful weekend, and I will see you next week. Let's get it.